GI tract lab, we will talk about some gross endoscopic and microscopic evidence of some of the diseases encountered in the GI tract. First of all, we will talk about the angiodysplasia. Angiodysplasia is a condition affected elderly patients, and it's most commonly affected the right side colon, in which the blood vessels at the submucosal layer will be abnormally dilated, and this will lead to symptoms like bleeding per rectum, for example, or abdominal pain. In this patient, we can see in endoscopy the dilated blood vessels, and we can also do the angiography examination, in which we inject dye or contrast dye to the venous system of the patient and to highlight the vascularity. And in this patient, you can identify the irregular vasculature here. This is consistent with the diagnosis of angiodysplasia. Okay, as we said, angiodysplasia is the presence of irregularly dilated venous or capillary channels at the submucosal layer. This lesion is usually small in size and less than 0.5 centimeter, and making it hard to be seen by endoscopy. As we said, there's also another test, which is the mesenteric angiography test, or even taking a biopsy from the patient. This is the microscopic appearance of the colon. We have the colonic mucosa at the left side, and after the mucosa we have the submucosal layer, then we have the muscularis layer. At the submucosa, normally the submucosa contain the loose connective tissue and blood vessels. In this patient, you can identify the abnormal dilatation of the blood vessels consistent with the diagnosis of angiodysplasia. Okay, this is the normal gross appearance of the small intestine, specifically the terminal ileum. In this patient, this is the terminal ileum mucosa, and this is the ileocecal valve, and then we will have the cecum. This area of the intestine, you can identify the brown, darker patches at the submucosa, and this is a higher magnification. So we have these dark brown patches, which is the lymphoid tissue present at the submucosal layer. We call it Pierce patches, and this is very important because some of the lymphoma can arise from this tissue. This is the endoscopic appearance. Here is the normal microscopic appearance of the small intestine. The small intestine is characterized by the presence of the villus architecture. Villi mean finger-like projections, lined by a single layer of columnar epithelial cells, and some of these cells have a mucin. We call it goblet cells. So the goblet cells in the small intestine is small in number, while just to compare it with the colon, later on the colon have numerous goblet cells. So this is the normal architecture of the small intestine. We have the villus architecture lined by these single layer of simple columnar epithelium, with some of these cells having the mucin. We called it goblet cells. And this architecture, the villus architecture, is actually very important because it increases the surface area. That's very important for digestion and absorption. Small intestine can also suffer from intestinal obstruction, and the main causes of intestinal obstruction is as follows. We have the adhesion, which is the main cause, and the patient usually have a previous history of operation or surgery, and this surgery can lead to fibrous tissue and adhesion between the bowel loops, and so lead to intestinal obstruction. The other cause is the hernia. Hernia is when there's a defect in the abdominal wall and the fascia, and so the intestinal bowel loops will protrude through the hernia, and that will lead to compression and obstruction. Neoplasia, the primary carcinoma of small bowel, is actually rare. However, the secondary neoplasia, which is the metastatic carcinoma from other organs like colon, ovary, pancreas, or stomach, can lead to intestinal obstruction as well. The volvulus is when there's a twisting of the bowel loop around itself, or there is a twisting of the mesentery as well. Intussusception when the bowel invaginates itself, so we will have the lumen will engulf itself, so we'll end up with a lumen inside a lumen, which we call telescope appearance. And the last one is the stricture formation. Stricture formation can result from inflammation, like in patients with inflammatory bowel disease, specifically Crohn's disease, or in patients with infection like TB, tuberculosis, enteritis, or when there is a foreign body material that will lead to irritation and so on, inflammation and structure formation. This is a gross appearance of the adhesion here in the abdomen. You can identify the fibrous band that connect these two loops together, and that will lead to adhesion, compression, and obstruction. Another example for intestinal obstruction. This is a long-standing obstruction because the bowel is underwent infarction. You can see the difference between the normal bowel at the bottom. Here we have the normal bowel which have the pink color, while the one infarcted at the top have the red infarcted darker color because of the infarction. And as we said, the main causes of the intestinal obstruction is adhesion due to previous surgery, hernia, and metastatic carcinoma. This is an example of the volvulus. Volvulus, as we said, is the twisting of the bowel around itself, or the twisting of the mesentery. In this example, we have the volvulus at the level of the cecum. The main two sides of volvulus is the cecum and sigmoid colon, because these two sides are having the larger diameter, and they also are a retroperitoneal organ, so they can move freely in the abdomen, relatively freely, so they can have a risk to develop the volvulus. Okay, and so as we said, the volvulus can lead to intestinal obstruction and infarction. This is the infarcted loop here, and usually the intestinal obstruction will lead to compression of blood vessels, and so will lead to ischemia and infarction. And this obstruction as well will accompanied by obstruction of venous return as well. So this segment of the bowel will appear congested and swollen due to decrease of venous return. And at this level, the bowel is actually okay, at this level, the process is actually reversible. So when we relieve the obstruction, the patient will not suffer from infarction or ischemia or infarction. This is another example of infarcted bowel due to volvulus. The volvulus here is occurred at the level of mesentery. This is the twisting mesentery. So we have the entire loop will suffer from ischemia because the mesentery is the one having the blood supply to the bowel, and this loop is the most affected one. Here we have the dark red infarcted loop. The volvulus can occur in adults and also in children. However, it's most common in adults. In adults, it can occur in equal frequency in both small intestine and large intestine, while in very young children, the volvulus almost always occur in a small intestine. This is an example of the intussusception. As we said, the intussusception is the engulfment of the lumen engulf itself. Like in this example, we have two lumen, a lumen inside a lumen. We call it telescope segment. So this is the example of the gross appearance of the intussusception. And the intussusception will lead to intestinal obstruction and infarction as well. Okay, this is the early signs of the intestinal infarction or ischemia, which is the hyperemia. Hyperemia is the mucosa looks red in color, and this usually occurs due to generalized decrease in blood supply due to hypoperfusion. The hypoperfusion can result from hypotension, like in patients with hypovolemic shock, or in patients with cardiogenic shock, or for example if he have a large amount of blood loss, or due to mechanical obstruction like presence of hernia, volvulus, or interception. However, in patients, if the patient have, for example, atherosclerosis, or if there is atheroma that block one of the blood vessels that supply the bowel, the patient will not suffer of effect, or will not affected largely of the ischemia due to that the bowel is a highly vascularized organ, so there will be another blood vessel that will perfume this organ. This is a higher magnification of the early ischemic changes. Here we have the hyperemia of the mucosa, and at some part of the mucosa we can identify the yellowish color, which is the exudate deposit above the mucosa. And as we said, it's very hard to have infarction due to atherosclerosis disease because this organ is widely vascularized and has a very anastomosing blood vessels channels. This is the microscopic appearance of the hyperemic mucosa we just saw in the previous picture. You can identify the three layers of the bowel. We have the mucosal layer, then we have the submucosa and the muscularis mucosa. You can see that the submucosa and the mucosa is actually not that affected, it's still intact, except we have some congestion of the blood vessels, while the most affected layer is the mucosal layer. Here you can see that the mucosa is replaced by a necrotic tissue. There is a necrotic tissue which form the exudate deposit we just saw in the previous gross picture. This is the higher magnification of the ischemia changes that affected the mucosal layer. The mucosal layer underwent necrotic changes. It's replaced by necrotic tissue and inflammatory cells, mainly neutrophils. This is the endoscopic appearance of the exudate deposit. Here we have the yellowish deposit above the mucosa. This is an example of the perforation of, this is an example of purulent peritonitis, which is an infection of the peritoneal cavity, and it's usually due to perforation of any organ from the esophagus to the colon. And in this patient specifically, the patient have ovarian carcinoma. The ovarian carcinoma metastasized to a sigmoid colon that lead to obstruction, and with this obstruction, a progress that will lead to severe dilatation of the sigmoid and then perforation. And with perforation, the feces and the material from the bowel will leak to the abdominal cavity, and that will lead to the inflammation or infection of the bowel cavity, which we call peritonitis. And this material here, which is yellowish in color, is the purulent exudate, and here's the infarcted organs of the abdomen. This is an example of the small intestine tumor. We have here yellow firm tissue mass, soft tissue mass, which is representing carcinoid tumor. Actually, the tumor of small intestine is rare, and there's some of these tumors are benign and other are malignant. One of the benign tumors are the leiomyomas, which is a smooth muscle tumor, and we have also the fibroma, neurofibroma, and lipoma, which is the adipose tissue or fatty tissue tumor, benign. And we have also the carcinoid tumor. Carcinoid tumor is a benign tumor usually. However, it can grow into a large size and metastasize and be a malignant tumor as well. And the patient, if he has a larger tumor, can be presented with signs of intestinal obstruction. This is the microscopic appearance of the carcinoid tumor. This is the mucosal layer here, and we have the submucosa. At the submucosal level, we can identify the nest and sheets of blue cells. Here are the blue cells, which is representing the cells of the carcinoid tumor. A higher magnification of the cells. The cells are forming a nest, and all these cells are uniform, small, blue in color. They have a characteristic chromatin pattern, which is dot-like. Here we have some of these chromatin are like a dot, and so it's called a salt and pepper, which is characteristic for neuroendocrine tumor. And then as we said, the carcinoid tumor is usually benign, while some percent of this tumor can be malignant and metastasize. And when the patient have metastasis of this tumor to the liver, just to the liver, the patient will develop carcinoid syndrome. Carcinoid syndrome is a syndrome in which the patient have elevated serotonin level, which is a hormone that's secreted by these neuroendocrine cells, and so the patient will be presented with a flushing, fever, diarrhea, and other symptoms, and the patient will not develop this syndrome unless he have a liver involvement, because the liver is the main site that's responsible for the metabolism of serotonin. So if the liver is free of tumor, the liver will break down all the serotonin and the patient will not suffer of the carcinoid syndrome. However, if the patient develop metastasis to the liver will not be able to metabolize the serotonin and the patient will have the carcinoid syndrome. Okay, this is another endoscopic view of the lower endoscopy. We can identify the multiple polyps seen in the small intestine. We have multiple polyps, small in size, and these polyps are hamartomatous in nature. These are benign, and this is consistent with the patient having a syndrome of Buerger's syndrome. This is a rare autosomal dominant condition associated with polyp, can be seen throughout the GI tract, and in patients with this syndrome has a higher risk to develop also malignant tumor or invasive malignancy in GI tract and also in other organs. This is another endoscopic appearance of the multiple hamartomatous polyp seen in the Buerger syndrome. This is another example of the intestinal obstruction due to obstruction by a tumor. And as we said, the primary tumor of the small intestine is rare. However, the more common is the secondary one, metastasis from other organs like colon, ovary, pancreas, or stomach. And in this patient, we have a larger tumor here, which is a metastatic tumor that obstructs the lumen and lead to manifestation of the intestinal obstruction. Another example of our pattern of metastasis, intra-abdominal metastasis, is we call the peritoneal seeding. Peritoneal seeding because the nodule of the tumor looks like seeds. So it's very important because it's maybe characteristic of some tumor over the others. And in this peritoneal seeding, usually the tumor nodule are small and seen at the peritoneal surface of the abdominal organs, and it can also grow to a larger size nodule and lead to external compression and intestinal obstruction as well. The patient with peritoneal seeding will also be presented with fluid inside the peritoneal cavity, which we called ascites. This ascitic fluid can also be withdrawn by biosynthesis method, and then we can examine this fluid under the microscope and identify the malignant cells. This is the microscopic appearance of carcinoma. Here we have the adenocarcinoma. We called it adeno because the tumor is forming a gland. So as we said, the primary tumor of the small intestine is very rare, but when we have a primary tumor of small intestine, the majority of these tumors are arising from ampulla of Vater, and which can lead to symptoms because of the biliary or pancreatic duct obstruction. This is the endoscopic appearance of this tumor. You can see this large tumor which have ongoing bleeding here as well. Okay, another type of malignancy can also arise in the GI tract is the lymphoma, and the most common type is the non-Hodgkin lymphoma. And as we said, the bowel have a normal lymphoid tissue that is presented at its layer like the Peyer's patches we just saw in a previous picture, and also there is what we call the mucosa-associated lymphoid tissue or gut-associated lymphoid tissue, which is called MALT. This is a normal lymphoid tissue presented at the wall of the bowel, and if it's underwent a malignant transformation, the lymphoma can arise from this tissue, which we called maltoma. In this patient, we have multiple polypoid masses here, which is tannin color, and this patient have HIV positive. He has an AIDS patient, and AIDS patients are having a higher risk to develop lymphoma, which is higher grade than other patients. This is the microscopic appearance of non-Hodgkin lymphoma. As you know that we have the crypt of, which is normal here. We have the normal crypt of the colon, and this is the lamina propria. The lamina propria usually contain a loose connective tissue and some of inflammatory cells and blood vessels. In this patient, the whole lamina propria is filled with sheets of these malignant cells. So it's filled with sheets of these neoplastic cells. We will see these cells later on in higher magnification. This is the higher magnification. We can see that these cells are highly atypical. They are pleomorphic. The cells are variable in size, and they have a prominent. Some of the cells have prominent nucleoli, and there is also increased mitotic activity. So, as we said, this is an example of the intestinal lymphoma, and the non-Hodgkin lymphoma is more common than the Hodgkin one. An example of the congenital anomalies which is seen in the bowel, we have the diverticulum, and we have atresia, duplication of the lumen, and other congenital anomalies. In this example, you can see that this is the normal appearance of the lumen, and at this area we have an outpouching of the bowel wall toward the outside. This is called diverticulum, and the most common example of this diverticulum we call the Meckel diverticulum. Meckel diverticulum can be presented with symptoms mimic the acute appendicitis, and you have to memorize the rule of two. Rule of two in Meckel diverticulum. These congenital anomaly account for 2% of population, and they are usually located 2 feet from the ileocecal valve, and they are usually measuring 2 inches in length. So there is a rule of 2 in Meckel diverticulum, 2% of population, 2 inches in length, and 2 feet from ileocecal valve. This is another example of the Meckel diverticulum here, which is excised because the patient have ulceration. This Meckel diverticulum can contain an ectopic tissue, most commonly a gastric tissue. So the gastric tissue will secrete gastric acid, and that will lead to ulceration of the mucosa and symptoms. And the patient will have symptoms mimicking acute appendicitis. And also this tissue can also have ectopic pancreatic tissue, which can have a large size tissue that will lead to intussusception and intestinal obstruction as well. An example of the congenital duplication of the lumen, this is the terminal ileum, this is the cecum, which has the larger diameter, and the ileocecal valve, and here at the level of ileocecal valve we have the other lumen, blind end segment, which is the duplication congenital abnormality presented soon after birth. This is here we have two pictures to compare between the normal small intestine mucosa, which has the villus configuration here. This is the finger-like projection, and it's lined by a single layer of simple columnar cells, with some of these cells having mucin. We call it goblet cells. While on the right side we have effacement of the villus architecture. There is shortening and effacement and sloughing of the surface because this patient have a disease called celiac disease. In this disease, the patient have a gluten sensitivity. The gluten is material which is presented as grains, cereals. So the patient will have an increased inflammatory cells. The patient will have increased inflammatory cells in the lamina propria, and these inflammatory cells are usually plasma cells and lymphocytes. They will attack the epithelium. As you can see that this is the epithelial cells, and there is increased lymphocyte inside the epithelium, which we called intraepithelial lymphocytosis. So there is 2 microscopic signs in the celiac disease. The first sign is the effacement or the sloughing of the villus architecture, and the other sign is increase in the intraepithelial lymphocyte. Those patients, and 95% of these patients have this antigen, DQW2, histocompatibility antigen. higher magnification of the celiac disease in patients with a small intestine. They have increased inflammatory cells in the lamina propria, as we said, and they are usually plasma cells and lymphocytes. And as we said, patients have sensitivity to gluten, which is contained protein gliadin, can be seen in cereal like wheat, oats, barley, and others. And the patient will be put in a gluten-free diet, so not to have this inflammation process, and so symptoms, the patient will be presented with malabsorption like diarrhea and weight loss. We can also examine for antibodies in the serum. Okay, and this is another example of disease can lead to malabsorption. The patient will be presented with diarrhea as well. This because due to infection with Giardia. This is a protozoa or parasite or microorganism which has this characteristic sickle cell shaped or crescent shape, like from the side when you examine it from one side, while if we examine the microorganism from front, like this one, you can identify the two nuclei which resembling the eyes. Okay, this is the normal colonoscopic appearance of the different parts of the colon. You can see that the mucosa is smooth, glistening, there is no ulceration, no masses, no polyps in the cecum, in the ascending colon, in the transverse, splenic colon, splenic flexure, sigmoid, and rectum. This is the normal structure of the outsider layer of the colon, which is a thickening of the longitudinal smooth muscle. A thickening of the longitudinal smooth muscle will lead to the formation of tinea coli. This is the white linear band. This is the normal colonic mucosa. You can see that there is no villus architecture like the one we see in the small intestine. This is the normal histology of the colon intestine. We have a crypt and lamina propria, then we have the submucosa, and in the submucosa we have the lymphoid tissue we call gut-associated lymphoid tissue, and we said that this tissue can also prone to transform into lymphoma. An example of a disease which is called pseudomembranous colitis or enterocolitis, in which the gross appearance of this disease, the mucosa is hyperemic and covered with white, green to yellow material, which is a membrane-like material, which is called pseudomembrane. This is due to infection by bacteria called Clostridium difficile, and other bacteria also can cause this appearance, like Staph aureus, other fungi like Candida. And usually the patients have a history of broad-spectrum antibiotic usage. This is the endoscopic appearance of the pseudomembranous enterocolitis. We have the yellow to white membrane-like material covering the mucosa. This is another example. We have this material which is green to yellow in color, membrane covering the ileum. This is the microscopic appearance of the pseudomembrane which is covering the mucosa. This is the mucosal layer, and this is the submucosa. And above the mucosa we have this cover of the pseudomembrane which is composed of necrotic tissue and inflammatory cells. A higher magnification, this is the mucosa which is underwent necrosis as well, and this is the pseudomembrane which is composed of numerous inflammatory cells, mainly neutrophil and necrotic tissue. Okay, this is the normal appearance of the appendix. Just you have to just remember the normal appearance of the appendix. It has the white color and smooth outer surface, glistening surface. And we have also the here through endoscopy you can identify the appendiceal orifice. This is an example of inflamed appendix, which is a disease called acute appendicitis. And as you can see, the appendix is larger in diameter and it is brown with a rough outer surface, and there is a lot of exudate on the outer surface. The patient will be presented with abdominal pain, fever, and also on CBC we can see there is an increased white blood cell count because of the inflammation. Another example of the acute appendicitis. This is the tip of the appendix, which is bisected. You can see the exudate on the mucosal layer and the congested whole wall of the appendix and the rough outer surface as well. Another example of acute appendicitis, which is congested, swollen, and also have an exudate deposit. This is a microscopic appearance of acute appendicitis. This is the normal mucosa here, while in this area we have a sloughing or ulceration of the mucosa due to the inflammation, and the whole wall of the appendix is infiltrated by the inflammatory cells, and mainly acute inflammatory cells, which is neutrophil. This is the higher magnification. This is the normal mucosal crypt, and submucosa and lamina propria is infiltrated by very heavy inflammatory cells, usually neutrophil, which forming the neutrophilic exudate. This is the higher magnification of the muscular layer of the appendix, which is infiltrated by neutrophil inflammatory cells, and as we said, the patient will have elevated white blood cells. This is an example of polyps that can be seen in the colon. We have mainly two types of polyps. We have the hyperplastic polyps and we have the adenomatous polyp. The hyperplastic polyp is a benign polyp. They are just an exaggeration of the normal colonic mucosa. They usually seen in rectosigmoid area. They are usually small in size, less than 0.5 centimeter, and usually seen in middle-aged patients. These are the two examples. And the other type of polyp we called adenomatous polyp or adenoma. There is three types of adenoma depending on the histological appearance. We divide them into tubular adenoma, villotubular, and villous adenoma according to the histological appearance of the polyp. And as we said, this type of polyps are dysplastic polyps. They are pre-malignant and the patient can develop invasive malignancy from these polyps. And in patients who have these mutation, ABCs, MAD, KRAS, and B53 mutation, may have the higher risk of developing invasive carcinoma. Another example for endoscopic appearance of this adenomatous polyp. This is the last picture. This is the histological appearance of the adenomatous polyp. Just compare between the dysplastic mucosa at the tip of the polyp and the normal mucosa at the bottom. This is the normal mucosa, which has a single layer of epithelial cells with basally located nuclei, and we have a lot of goblet cells here. While in the dysplastic mucosa at the tip of the polyp, we have hyperchromatic nuclei and stratification of the nuclei, and there is decreased number of the goblet cells. So we have a goblet cell depletion, and as we said, these polyps are pre-malignant and can lead to invasive malignancy. This is another example of the endoscopic appearance of the adenomatous polyp. هي آخر سلايد. في حد عنده سؤال؟